then have some background knowledge of some of the conditions that we will be discussing today. And we'll also talk a little bit about how to present the images and how to present them kind of for exam purposes. And there'll be a nice summary at the end of each case. So for me, I think having some sort of framework is really helpful. And there are always clues in the image. So deciding whether the patient, how old the patient is, if that hasn't been given to you in the history. So seeing whether they're skeletally mature or immature can sometimes be very helpful, particularly when thinking about certain conditions. And then looking at the lesion in question. So you've found the lesion, which bone is it in? Which part is it in? Is it in the epiphysis, metaphysis, diaphysis? Interrogating the lesion, is it well-defined, ill-defined? What is the internal matrix like? Is it predominantly lucent, sclerotic? And then trying in your mind when assessing that lesion to decide whether the lesion is aggressive or non-aggressive. So there are certain things that we can look for, and the first is periosteal reaction. And not all periosteal reaction is aggressive per se. When a lesion grows rapidly, you're having interrupted growth, so you're having more aggressive type periosteal reactions, such as hair on end, spiculated, that lamellated or onion skinning type of periosteal reaction. Whereas when something is either slowly growing or healing, so for example, in a fracture, if you have a fracture healing, that can be nice and smooth and solid and continuous, which is non-aggressive. And then looking at the cortex, and the image on the slide is a nice example where possibly at the ulnar border of that distal radial metaphysis looks fairly ill-defined, and you'd be raising the question of whether there is cortical destruction at that margin. And then predominantly you'll be shown plain films, and you'll be looking for distortion of the adjacent soft tissue planes and trying to get some more information of whether there's an associated soft tissue mass. And yeah, pathological fracture is pretty self-explanatory. So nice summary here of some of the conditions that we will be looking at today. So it's a nice table, and I have to specifically say thank you to Sam, who has actually written the majority of these slides today. This is a lovely table here. So nice age discriminating factor. So under the age of 20, aggressive lesions. So if any of your cases do appear to be an aggressive lesion, you've got your differentials. Non-aggressive and lytic, and I'm sure you all know of that A, B, C, D, E, F. So we've got the nice mnemonic there to help you think of your differentials, and then some examples of non-aggressive and blastic conditions there. Right, so if I could have candidate 1 to have a little go at describing the first case.
Okay, this is a frontal radiograph of left upper limb, humerus, and the left shoulder joint. I see there is in the proximal of the left humerus, there is bony lesion showing a lucent bony lesion with well-defined sclerotic margin. In this view, I suggesting this is projecting from the bone. It is narrow zone of transition. I need another orthogonal view to more visualize the other view for the bone. In the other view, however, in the right side, not clearly it's masked by the scapula. However, I'm more going with non-aggressive bony lesion, as I see narrow zone of transition. And the cortex appear to me be intact. So, for me, I think this is could be non-aggressive bony lesion, Osteochondroma, the first possibility for me.
Excellent. I'm sorry, I didn't catch your name. What was your name?
Candidate 1.
Candidate 1, lovely. Okay, so that was a really nice description. excellent description. I like that you ended on whether you felt the lesion was non-aggressive or aggressive. If this plain film landed in your reporting pile, would you be, with the clinical information given that this patient has pain, would you be suggesting anything?
If the patient have pain, I suggesting there is a malignancy change of osteochondroma. I will review if this patient has MRI before to see the cartilage cap thickness. If this is more than 1.5 centimeter, I will going with chondrosarcoma transformation of osteochondroma. I was also to rule out soft tissue change for this advanced for the patient from osteochondroma benign to the chondrosarcoma.
Okay, great. So if I show you the MR here, and you correctly identified this as an osteochondroma, you can see that medullary continuity within the lesion. You talked a little bit about the cartilage cap, and yeah, you're right. So you're looking for anything over about 1.5 centimeters in adults. It varies in children. I think it's more of a clinical, you'd be guided a little bit clinically. Is there anything that you wanted to mention on the MR?
MR in the this T1 sagittal view, I see it is this is a bone. Sequence of cartilage cap is for me in my T1 sequence. It is continuous measurement in this set of the image. In the stair view, I see some high signal. Some high signal in the sketches of the bony lesion, other than the cap. For this one. So I think this could be cause of the pain for the patient. Until for me now, I don't have the measurement clear for me. So I'm keeping with the Chondroma as no soft tissue.
Yeah, good.
Sorry,
it was breaking up just towards the end, but yeah. So osteochondroma. I know that you can't measure it, but it's not more than 1.5 centimeter. So just a little summary about osteochondromas. You can get many different types, but usually you want to see that corticomedullary continuity with the kind of, as described inside, parent bone. When you're looking at the cross-sectional imaging, it's really important to assess for any mechanical complications. So if someone is presenting with pain, it may be that the osteochondroma is compromising, say, an adjacent neurovascular structure. And as candidate 1 correctly identified, that you would want to look at the cartilage cap and any marrow abnormalities. So there are kind of other associations when you have multiple osteochondroma. It's known as multiple hereditary exostoses. And here's a lovely example of a patient with we can see lots of different types, so broad-based, sessile, pedunculated osteochondromata throughout their limbs. This is an autosomal dominant condition, and again, you would be assessing clinically for any pain or mass enlargement. I think that there's a very low incidence of transformation, around 1 to 2% to chondrosarcoma. Candidate 2.
Yeah.
You'd like to have a go at the second case?
Yeah, so I'm given with the frontal and radiograph of the right hand of a skeletally immature patient and corresponding lateral image of the middle digit. So I can see that there's a well-defined latex lesion in the proximal phalanx of the third digit, causing bony expansion and cortical thinning. And I can appreciate some thin, incomplete septations within. However, there is no periosteal reaction, and overlying soft tissue shows swelling. It has not involved any of the joint proximally, and no other lesions are seen in any other bone. So, can I know what has the patient presented with, the history for the patient?
They had trauma playing netball, and they had some pain in their ring finger.
So, based on the presentation and the age of the patient and the location of the lesion, my first differential would be Enchondroma, and I have never seen ABC here, but it could be a simple bone cyst. Yeah, the lesion is more of epimetaphyseal. Yeah.
And
so,
would you be saying this is aggressive, non-aggressive? Would you be suggesting anything else?
So it is a lytic lesion, and since there's no peritoneal reaction, soft tissue or anything on the particular radiograph, I won't be able to comment. I would suggest a cross-sectional imaging, particularly an MR of the lesion, to comment upon it.
You would suggest it? I'm really sorry, you keep cutting out.
Yeah, a cross-sectional MR, yeah, to comment upon its aggressiveness and in further involvement of other structures.
Okay. So I would agree doing an MR would be helpful if the patient were having symptoms. Enchondromas are fairly common. I wouldn't suggest doing an MR for every enchondroma that you see. But that was really well presented, really nice. You would hope that if you were to be given an exam case like this, that a case would have that very typical ring and arc chondroid matrix. I've given you a bit of a tricky one, but you handled that really nicely. And here you can see it's central diaphyseal. They're usually expansile lesions, and you can see that nice thinning of the cortex and kind of endosteal scalloping that occurs with these lesions, most commonly in the hands and feet. And you can get pathological fracture, so I was pleased that you were looking at the cortex and looking for some periosteal reactions. So again, a nice summary slide here for you all. They're benign tumours, and a peak age is 10 to 30 years. So half occur in the hands and feet. And that is pretty much the most common place, I would say, you see them, but you can see them in the proximal humerus, proximal femora, and there's a very low incidence of them transforming to chondrosarcoma, but you have to be looking for those, as candidate 2 was, for that periosteal reaction. When you see enchondroma and you see more than one, multiple ones, for example, in this case, you start to think about Ollier's disease. Now, this is a non-hereditary abnormality, and you can see here where, we have lovely examples of multiple enchondromas, and the difference in this case is the risk of transformation into a chondrosarcoma does jump up to around 25%. Very similar appearances to the others that we saw previously. And another consideration is Maffucci syndrome, and this is when you have multiple enchondroma with multiple soft tissue hemangiomas. So you may see unilateral involvement of hands and feet. Now, the malignant transformation is much more common than in Ollier's, and you can see this is a really nice hand X-ray showing multiple enchondromata with soft tissue abnormalities. So you've got increased density and almost phleboliths in some of the soft tissues, pointing out those soft tissue hemangiomas. Okay, back to candidate 1.
Okay, sorry. This is an EV radiograph of knee joint of immature children. I see there is lytic lesion in the proximal metaphysis of tibia, exenteric. There is narrow zone of transition. There is cortical not clear for me. I think no cortical creating, no soft tissue swelling. There is no matrix classification. The upper end adjacent to the epiphysis not reaching the articular surface. It's limited by the epiphyseal plate. There is, I think, this fine internal septation, and the one set of the image of T2 stair for the concerned lesion, showing multiple air fluid level with high signal and low signal alternating. This is going with aneurysmal bone cyst, more likely. The other differential is not here. Telangiectatic osteosarcoma. However, this is a lesion concerned more with the bone expansion and do not has pre-ossea reaction. It is non-aggressive bony lesion. It is aneurysmal bone cyst.
Excellent. Really nice description and summary. You've pretty much stolen everything on my next slide, so well done. This is an aneurysmal bone cyst. They're usually lytic, expanded, eccentric, tend to occur within the metastasis but can expand into the soft tissues. And you can see on the axial image here, we have a trace of periosseous edema. They tend to be well-defined, thin sclerotic margins, and see the characteristic fluid levels as demonstrated on this axial image. I was actually always taught by one of my consultants that ABCs tend to occur in the presence of another lesion. They rarely occur on their own. So you'd be really looking for and interrogating to ensure that there isn't another or underlying tumour along with that ABC. Predominantly these occur under 20, and we've seen a lovely example and description by candidate 1, who also mentioned the telangiectatic osteosarcoma. So an example here. So when trying to differentiate between the ABC and the telangiectatic osteosarcoma, so you've got the ABC at the top left, and the telangiectatic osteosarcoma on the right-hand side. And you can see how ill-defined those margins are. So the arrows are pointing to the sacrum, whereas on the left with the ABC, it's far more well-defined. And also the infiltrative kind of process around the lesion for the telangiectatic osteosarcoma. So looking for those more aggressive features for the latter. Okay, candidate 2.
Yeah, so I'm given with the frontal and lateral radiograph of the left arm, including the shoulder joint and part of elbow joint. So I can see well-defined expansile lytic lesion in the proximal metaphysis of the humerus, which has got a few septations within, causing endosteal scalloping and a wide zone of transition. Okay, so there's no significant periosteal reaction. The overlying soft tissue is well. The joints and other bones appear normal to me. Okay, so the differentials on this would be, since it appears to me as a ground glass matrix, so I would say put fibrous dysplasia on top and later ABC. Yeah.
Again, I'm really sorry, you cut out. What was your top diagnosis?
Fibrous dysplasia.
Okay. And what other things occur in children in this location?
Aneurysmal bone cyst, ABC.
Okay, and so we've just seen an aneurysmal bone cyst, and they tend to be eccentric, so this is fairly central.
Yeah.
And predominantly within the diaphysis, extending into the metastasis, proximally, I guess, but it's predominantly within the diaphysis. So again, any other ideas? If this is in your A&E emergency department, plain film reporting pile, and patient presents with a fall, what would you be suggesting? Would you be suggesting anything?
I would further take up the patient for cross-sectional imaging.
Okay. Can you think of any other conditions that occur? In this region? Don't worry if not. If I show you an MR?
Yeah. So the PDF is image. No. Yes, the PDFS image shows the lesion to be showing me the blood fluid levels and is hypertense on T1. And again, there's layering in the actual PD fat site images. So, could it be? I'm not sure. Could it be a brown tumor?
Okay.
But it's showing me the fluid levels. So my differential of bone cyst is on the top. Simple bone cyst.
Okay, simple bone cyst.
Mm-hmm.
Okay, good. Okay, so I think this is a tricky case. You tackled that really nicely. The key features are, I guess it's intramedullary. The one that I've shown you has actually fractured before, which is why you're seeing on the plain film.
Yeah, the lateral cortex. Yeah, lateral cortex
fractured before within the proximal part of the lesion, and that's why I think it gives that kind of fibrous dysplasia appearance. But most importantly, in a child of this age, in this location, with some of those characteristic findings of a unicameral or simple bone cyst. Now, the layering actually suggests that they've had a previous fracture. The plain film and the MR don't show an acute fracture, but that layering within the lesion nicely picked up by candidate 2 from the axial imaging, particularly, you can see that there has obviously been some hemorrhage within that. So a nice summary slide here. Again, these are benign lesions. They can look complex, particularly if they've had previous trauma and fracture. 85% occur in the first 2 decades, and usually they do spontaneously resolve. Some of them do require treatment, and they decompress them, bone graft them, particularly if they've had fracture. It's a very, very common site. So in the proximal humerus, at least 50%, and 25% in the proximal femur. So as the child grows, they tend to move away from the physis. So you can see there's a fairly long lesion. And someone has also mentioned in the chat, you get that pathognomonic fallen fragment sign when they do have a pathological fracture through the lesion. Candidate 1.
Okay. This is an EP and lateral radiograph of the left knee. There is a lytic lesion in the proximal metaphysis and extending to the epiphysis of the tibia. The lesion is showing partially in the lower part, narrow zone of transition. There is also a fine trabeculation inside. This is extending to the articular surface. In this mature bone, I will go in with giant cell tumor. I don't see any fracture of surrounding cortices. I don't see any soft tissue mass. So this is a giant cell tumor for the patient.
Okay, good. Can you talk to me a little bit? You said narrow zone of transition. Can you talk to me a little bit about the lateral border of the lateral margin of the lesion?
The lateral margin of the lesion is not sclerotic. There is no sclerosis surrounding it. However, I see the partially sharp or partially irregular. It's defined partially. So is this confusing to be as narrow zone of transition here in the lower border of the lesion?
Okay. Here. And what do you think about the cortex of the medial proximal tibia?
The medial proximal tibia. In the EP view, I don't see cortical breaching. Not clear cortical breaching here. No, I think there is some but it's not a definitive Bruce reaction. It's not clear for me.
Okay.
But however, in comparing the medial aspect of the lesion of the cortex in comparing to the lateral part, lateral cortex of the tibia, I think it is there is a thinning. Could be there is some thinning of the cortex in the medial aspect here, compared to the left side lateral aspect.
So, do you think this is aggressive or non-aggressive?
This for this affection of the medial cortex, I think we're going with aggressive bony lesion.
I'm sorry, you cut out. Aggressive or non-aggressive?
Aggressive. I think we'll go with aggressive.
Okay. What in particular are the features that you're citing for it being an aggressive lesion?
Aggressive bony lesion, usually I have a wide zone of transition. I usually have Bruce reaction, marked Bruce reaction. I see if there is soft tissue mass or swelling, considered for the pathology.
No, so in this case, what features are you seeing that makes you think this is an aggressive lesion?
It's worry for me is the medial aspect of this lesion. However, it's not clear. It's not clear to be.
Okay. Okay. Well done. This is a GCT. So I think this is a really nice example. It's lucent. They don't tend to have sclerotic margins. So actually, that's a nice discriminator. So it's a lucent lesion with no sclerotic margin. They tend to predominantly occur when the in skeletally mature. So when we were talking about the previous case of the unicameral or simple bone cyst, you know that was a pediatric case with open physes. You don't tend to see GCTs in skeletally immature patients. Now, the candidate one correctly identified there is some thinning, but actually there's some periosteal reaction along that medial border of the proximal tibial metaphysis, which is slightly concerning. So the GCT itself can be locally aggressive, and it's important to look for some of those aggressive features. 75 to 90% occur in the long bones, predominantly in older people, so 30 to 50, and they originate in the metaphysis and extend to the epiphysis and often abut the subarticular bone. They are generally eccentric with no sclerotic margin, and are, the words narrow zone of transition. I find using zone of transition a little bit confusing. I prefer describing lesions as well-defined or ill-defined, but I understand that's a personal preference. So they tend to be well-defined, and you very rarely tend to see them as lobulated or bubbly lesions, and they are associated with some genetic syndromes as suggested at the bottom of the slide. Differentials, as you can see on this slide, for GCT is Chondromyxoid fibroma, but as you can see in this slide and an example, you can see that sclerotic margin, and it appears a little bit more lobulated than the previous example of the GCT. There's a little bit more of a wider age range. So you tend to see these predominantly within the second decade of life. And here you can see a geographic lesion, a lobulated lesion with a sclerotic margin. They tend to be eccentric and expansile, but you don't tend to see that chondroid matrix. The name is a little bit of a misnomer, actually, so they tend to be predominantly lucent with that lobulated, bubbly appearance. I think this is candidate 2.
Yeah.
Yeah.
So, given with the lateral and frontal radiograph of the skeletal knee joint and proximal leg, full leg in lateral view of an skeletally immature patient, and I see multiple well-defined reticulocencies in the proximal metadiphyseal region of the tibia, and with sclerotic margins. The cortex is normal. There's no periosteal reaction, and the tibial epiphysis appears to me a bit ballooned up on the also the also the medial femoral epiphysis.
Sorry, what's ballooned? I missed that.
The tibiofemoral on the medial aspect, the epiphysis appears a bit. There is an asymmetry between the lateral and medial femoral and tibial epiphysis. And I can see some lucences in the frontal radiograph on the fibular lateral aspect of the mid-tibial diaphysis. The
recording has stopped. This meeting is being recorded.
The lesion shows sclerosis, well-defined sclerosis in the frontal radiograph. So this is a mixed sclerotic lytic lesion in the mid-diaphyseal, metadiaphyseal region of the tibia, with some asymmetry in the knee joint and bowing of the frontal bowing of the tibia. So if it is does the patient under fever, so I would put my infective etiology as the first differential. And
did you say infection?
Brody's abscess.
Okay.
Or
is this a typical location for infection?
No, it is not. And
where would you tend to see infection or Brody's abscess?
Why did I say Brody's? It would be more of tibial metaphyseal, distal tibial metaphyseal, or proximally. Could it be? Cannot think of a mixed sclerotic lytic lesion in an skeletally immature patient and child.
So don't worry about what the diagnosis is. Okay, I just don't worry if you don't know what this is. I'm not concerned by that. I'd like you to concentrate on whether you think this is aggressive or non-aggressive.
So it has caused a bowing of the tibia, or had the patient inherit the skeletally deformed bone. I would say the lesion is non-aggressive because I cannot see any periosteal reaction, soft tissue swelling, or
okay.
There's a narrow zone of transition. I can see the inferior lateral borders, the inferior medial borders, superior borders. Yeah,
good. Okay, so you're not seeing any aggressive features. You don't know what it is, and that's okay. That feels uncomfortable, but that's okay. You're trying to develop a safe framework. So when are you worried and when are you not worried? If you're not really worried, you can see that there's bony deformity, there's bowing of that tibia. And actually, if you look really hard at the anterior cortex on the lateral view, can you see anything along the anterior cortex?
Yeah, I see a lucency. So I was worried whether there's a fracture because of the sort of torus or something buckling sort of.
Okay.
Yeah, lucency. And also I can appreciate maybe it is an overcalling in the distal tibial epiphysis. I could see a thin linear lucency.
Okay, so we're thinking that the patient may have had a previous fracture.
Mm-hmm.
Does the MRI help you at all?
Yeah, so now the lesion has overgrown its origin and extended a bit into the soft tissue with an exophytic component, and it's T1 hypo and mixed intensity on T2. With subtle edema on the medial, but I can see the lateral cortex to the fibula. I can see it well defined, but the medial cortex is encroached and destroyed. And
so actually, do you mind if I stop you? Is that okay? Actually, the cortex is thickened. You have what looks like
Yeah, sorry.
Yeah, no,
Yeah, on T1 I can see the cortex well defined. It is basically growing into the cortex. So osteoblastoma would be my differential now.
Sorry, what was that?
Osteoblastoma, but it's not a typical location for it. Is it a diaphyseal and cortical osteoblastoma?
Okay.
Yeah.
So there are a few things that you can get in the tibia, and they're tricky. So in a pediatric population, we're thinking about osteofibrous dysplasia, fibrous dysplasia. This is a nice example of osteofibrous dysplasia. It has that mixed density. You have that nice sclerotic margin with a slightly fibrous component internally. There's no real aggressive features that the patient did have previously, a pathological fracture. We could see that nicely in candidate 2. It described that really nicely when there was thickening and a linear lucency within the anterior cortex. Around 50% of these occur under the age of 5. They tend to occur within the diaphysis. And you do have that nice sclerotic margin generally. It's very difficult to differentiate osteofibrous dysplasia from an adamantoma, but the age does help to be a discriminator in those cases. These tend to go down to the bone tumour centres and have biopsies, but there's nothing really that aggressive on the plain film. It was really trying to see that evidence of the previous fracture and trying to link that maybe the pain may be coming from that. Candidate 1, on the same theme.
Okay, I see this is an radiograph of the femur. I see there is a wide expansion of the intertrochanteric region and the proximal shaft of the femur. There is a few ground glass delicacy of the medullary cavity with expansion. There is no cortical breaching. The upper end showing clear edge of the pathology. The lower edge is continuous, not ill-defined, no soft tissue mass. I will going with in this region. I will going with fibrous dysplasia, more likely for me. Also, in this region, also what's called here is the specific lesion here is one of the fibrous lesion coming in this region. It is not aggressive lesion. This is benign one.
Good. Okay, excellent. So yeah, this is a nice example of fibrous dysplasia. They usually are, they can be mildly expansile, and you get that nice kind of ground glass, that smudged appearance internally, which is that matrix, that fibrous matrix. It tends to be poorly organized. So you're seeing this kind of smudged appearance. It can occur as a monostotic pathology or polyostotic, and there are multiple syndromes associated with those, which I'm sure you've all heard about, McKee-Norboites, Mazabrans, and you can get associated limb length discrepancies. Really nice example on the plain film, nicely described by candidate 1, and you can get the associated bone deformities, so that varus femoral neck, which is otherwise known as the shepherd's crook. A kind of good note just to put in here is, so the first image shows a nice example of the shepherd's crook deformity. The second image shows a lesion which I'd like you to be aware of. It's a used to be called a lipo. Oh, sorry.
Okay. Sorry. Cytoma.
So the lesion on the right used to be called a liposclerosing myxofibrous tumor. It's now thought to be on the spectrum of fibrous dysplasia. So it's just to be aware that those lesions tend to occur in the intertrochanteric or femoral neck lesion, and you can see that densely sclerotic focus centrally, and they tend to be a little bit more well-defined with a sclerotic margin. You can see the differences with the two images side by side there. Candidate 2?
Yeah. So I'm given with the frontal and lateral radiograph of right ankle joint of a skeletally immature patient with foot seen. I can see well-defined eccentric cortical-based lytic lesion in the lateral distal cortex of tibia, and with well-defined sclerotic medial margins, narrow zone of transition, no periosteal reaction, and some deficient cortex on the superior part. No soft tissue swelling, and no other lesion. So based on the appearance and location, my differential would be osteoid osteoma.
Okay, can I ask you just to tell me if you think this is aggressive or non-aggressive first?
It has caused a bit deficiency in the cortex, but based on the location appearance, I would still designate it as non-aggressive.
Good. Okay, so non-aggressive. Tell me what you know about an osteodosteoma. Why do you think this is an osteodosteoma?
It's based on the cortical location, but it's not that diaphyseal. Yeah, my second differential would be a non-ossifying fibroma.
Okay.
8, yeah.
Okay, good. So we'll come on to osteodosteomas later. But you nicely described the non-ossifying fibroma in this distal tibial metastasis. They tend to be long lesions, eccentrically placed. And this is a nice example of what's described as a bubbly lucent lesion. They tend to have that sclerotic margin. There's no periosteal reaction or really aggressive features associated with the lesion, as you really well described. When you follow these up, or when you incidentally follow these up, they tend to become a little bit more sclerotic until they completely remodel to normal bone. They are also known as fibroxanthoma, fibrous cortical defects. They're all on a spectrum of the same process. They're benign fibrous lesions. Really, the differentiator here is how large the lesion is, and that really decides what you call it. But a nice example, well described. These can be associated with neurofibromatosis type 1 and Jaffe-Campanachi syndrome. So just to have that in the back of your mind when you see multiple non-ossifying fibroma. I think we're on candidate 1.
Okay. Okay. This is a frontal radiograph of the knee, left knee, and AB and lateral radiograph. And following the cortices of this immature skeleton, I see the cortices of the femur. I see the cortice is continuous, complete, and following the tibia and fibula. The most worrying for me is there is in the right middle condyle of the femur, there is a rounded lucent lesion in the right femoral medial condyle with thin sclerotic margin. It is well defined. I see some soft tissue swelling. However, I don't see any evidence of effusion in the concerned joint space. I am worried about for this young age. I'm worried about infectious pathology. This could be a broad abscess. I need to do MRI for more delineation, and and delineation and characterization for this pathology.
Good. And any other differentials that you know of lucent lesions that occur in the epiphysis that you would include in your differential?
Other differential for lucent lesion in the epiphysis could be this what's called chondroblastoma for this region in the immature skeleton.
Excellent. Yeah, excellent. Well done. Nice description and really good differential, like sensible differential there. So this is a chondroblastoma. They tend to be tumors arising within the epiphysis of skeletally immature patients, and they generally affect the age group between 10 and 25. They tend to be really well-defined lucent lesions with thin sclerotic margins. And the differential really to be aware of here is the clear cell chondrosarcoma. It's a very rare low-grade variant of a chondrosarcoma. It also arises within the epiphyses, and really it's only the kind of discriminator here is age. And this is just to show you an example of what that would look like. So the plain film, you can see that fairly similar lesion really. If you have an AP radiograph, this patient is 35. And you can see that well-defined lytic lesion with the sclerotic margins, just as we did in the case before. And actually this lesion was picked up incidentally. The non-contrast CT in the top corner has an arrow pointed to the punctate calcification, which is the internal matrix of the lesion. It's really well defined. You can see that surrounding sclerosis. And then the MRI images at the bottom, once again showing that this is a really well-defined lesion with a thin sclerotic rim. And this was proven to be a clear cell chondrosarcoma. Candidate 2.
So I'm given with a frontal radiograph of the pelvis of a skeletally immature patient with a gonadal shield on. I can see fairly defined sclerosis in the right proximal metadiphyseal region of the eccentric cortex, and some lucency in the neck of right femur towards the trochanter. So this cortical based sclerosis with some internal lucency points towards the first differential of osteoid osteoma. And the lucency, I'm not sure whether I'm overcalling or is it a lesion in the femoral neck.
Are you talking near the greater trochanter?
Yeah.
Yeah, I think that's projectional. So tell me, what would you expect to see on the MRI?
So and this lesion would show me the nidus, the sclerosis lesion, and the MR.
So that is what you're looking for. What would
more it would manifest. More it would be seen to me as an edema of the bone.
Good. Okay. So you tend to see on the MR the reaction, right? You tend to see diffuse marrow edema. Which modality would clearly show you the nidus?
Bone. So for nidus, it would be CT.
Okay, good. So here you can see a nice example of that cortical thickening, the surrounding sclerosis. And the central nidus in the middle of that. So really well identified on the plain film. And you can see how this looks very different to the non-ossifying fibroma that you described before, candidate 2, yeah? Mm-hmm. So this is a bone-forming tumour. You tend to get that really thickened cortex and that adjacent sclerosis that we're seeing nicely on the CT and the plain film here. Whereas in that non-ossifying fibroma that you described, that cortex was really thin and it was really well defined, and you can see how ill-defined the osteoid osteoma looks in comparison. I hope that's helpful.
Mm-hmm.
Okay, summary slide. So we've already talked a little bit about it. The helpful information, if you can ask, is whether they have night pain, which is helped by non-steroidal analgesia. And these can occur anywhere, and we've got some great examples of them occurring kind of within the medullary cavity and intra-articular. These can occur everywhere. So in a case of a patient with pain, diffuse merit edema, this should be up there with infection as a cause. You tend to see that nice lucent nidus, which can have central sclerosis within it. And again, if you're lucky, the nidus tends to be small, so you don't always actually see it on the MR. The CT is really the clincher here, particularly in that case. And I'll just show you a couple of additional examples here of an osteoid osteoma. And you can see on the axial imaging, the last image here, how thick that reaction and that sclerosis is, where that nidus is sitting, and that kind of reaction that it's caused. Move along. So I think it's candidate 1.
Okay. This is an MRI in axial cuts of the brain. In the first one, the left side, this is the one submitted image. I see there is right frontal midline extra-axial, I think hypo-intense, well-defined mass. I think it is in T2, it is showing a high signal with internal low signal. And I think this is the right side contrast study showing well-defined, well-enhanced margin with low signal in the middle. This demonstrated this. Okay. Okay. In bone window axial cuts, this lesion frontal showing beveled edge with narrow lumen of the internal diplo and soft tissue component sequestrum in front of it, as demonstrating in the 3 volume rendering, and in soft tissue here in the sagittal view, showing enhancement of peripheral enhancement of the margin of this pathology. I think this is eosinophilic granuloma lesion in this age group, and this is pattern of bone appearance in the bone.
Lovely description, and I mean, I think those are quite tricky on the MR, to be given the MR to start with. It is part of a spectrum of histiocytic disorders, and you have lots that includes. So these can present with either a single lesion or multiple lesions, and the CT is a really nice example, particularly with that 3D recon of seeing that skull lesion with that beveled edge. And most commonly, I guess, in exams, you tend to be shown a child with a spinal film or imaging with a vertebra plana, very commonly. So again, this is another example of how aggressive and how different it can look in different bones. This is thought to be an aggressive lesion, quite rightly so. You can see it's very ill-defined. It's causing remodeling of that bone. The child went on to have an MR. I'm not sure the MR really helped to narrow down that differential. You can see how the LCH is actually quite aggressive appearing on the MR. So they were still worried that this was underlying tumor and ended up having a biopsy. So I'm going to move on. Candidate 2.
So I'm given with the frontal radiograph of knee joint with distal femur and proximal tibia. I have visualized skeletally immature patient, and I can see generalized sclerosis of the distal femur metadiaphyseal region with a band-like I can see a lucency running beneath the cortex and the sclerosis of the femur in the diaphyseal region, and rest epiphysis and tibia fibula appear normal. Soft tissues appear normal to me. So based on this sclerosis of the metadiaphyseal region, my differentials would be.
Before you get to differentials, can I stop you and just think about whether you can see any aggressive or non-aggressive features on the clinical?
I am not able to differentiate whether this is a lucency beneath cortex or is this a periosteal reaction. So I would say it is a periosteal reaction and attribute towards the aggressive feature of the lesion.
Okay. Is there anything that you would like to know about this patient before you start to give a differential?
Perhaps lab parameters would help. Biochemical values of phosphate, calcium, or lead toxicity.
Okay. Why? What are you thinking?
Yeah. Based on the periosteal reaction, my differential was of an osteosarcoma first, but then I was thinking if at all it is a metabolic disease of lead toxicity or.
It's quite focal for metabolic cause, isn't it? It's not affecting the safety of the fibula.
And then osteopetrosis, but.
If I told you that this is the patient's brain imaging, would
so
you...
I see a fourth ventricular mass and then solid cystic lesion here, and is it neurofibromatosis?
No.
Some form of no. The orbit is involved. I see a lesion of orbit cavernous sinus. I see a lesion in intraparenchymal basal ganglia too, and medullogerminoblastoma pedio and NF tuberculosis.
Do you think that the lesion in the brain looks aggressive? How does that link to the lesion in the bone? If it were an adult, what would you be thinking?
Is it a lymphatic? So parietal bone lesion appear. If had it been an adult, I would have the temporoparietal lesion. I would have said it to be a glioblastoma. Smith's.
So I think that this is a really nice case. Actually, Sam knows this case better than I do. I think the patient had a neuroblastoma, and the example is of a metastatic deposit in the dorsal femur. So thinking about metastases, I know in children it's not something that we jump to first, but having it there in the differential is really important. And then, thinking about other types of sarcomas, and you may be presented with, for example, lung metastases in a child, and thinking backwards. So you may not be given the original pathology, as in this case. You may be given a secondary or a metastatic deposit. And actually for, that was a medulloblastoma?
Yeah, there was a medulloblastoma, and if you go back to the one slide before, in posterior fossa tumors in kids, I know this can be, if it's adults, a bit different, but we are doing a pediatric talk. So posterior fossa tumors, it's hyperdense. In the fourth ventricle, the first thing you think of is medulloblastoma. Yes, you can think of other things like hemangioblastoma, but often, this is a non-contrast scan. You're thinking there'll be contrast enhancement with a bigger cystic component. The other things you think of is a pilocytic astrocytoma. Again, much larger cystic component. So, the others do have metastases down the CSF, so like neuromets, but then it's just an interesting case because take note of the timeline. So if you hadn't gotten that this was some sort of brain tumor, because I think it looks fairly aggressive, right? Because you've got your hydrocephalus there as well. And again, posterior fossa thingies, you would think brain tumors first. And then if you start to see that 2022, why have things changed? And things do look fairly dodgy, aggressive, with, cystic components, although I didn't give you the full slices. Then when you look at the post-contrast one, the bottom right-hand corner, it's a lot of enhancement. It involves the bone, it involves the brain, there's proptosis. It just all looks very aggressive. So you want to go down the route of, is this tumor progression? Is it going somewhere else? Of course, you can say, yes, it could be either a neuroblastoma with everywhere metastases. But I think that if you ask the key question, was the 2019 scan the only scan, and what was the symptoms, then I think it would help you to get to the diagnosis a lot quicker. But again, we are not giving you the full picture, so a lot of it you have to do a lot of assumptions. Okay.
Thanks, saving me again. So yeah, next. Candidate 1.
Okay. This is a left femur EB and lateral radiograph. I see there is the diffuse mousse eating infiltrating the medullary lesion involving the lower two half of the femur. There is Codman triangle process reaction. There is also I see some in the matrix in the medulla. There is denoting osteoid matrix, as well as soft tissue close to the bone. And this is young, this child. The cortex in the middle of this likely to be some medial surface breaching. So I dealing there is one zone of transition. I dealing with aggressive bony lesion. In this age group, I will going first with cerebral pathology, also sarcoma, Ewing sarcoma, and osteomyelitis. This is I will need to do CT cross imaging and contrast also MRI for further delineation. Okay, MRI T2. I see the lesion is extensive in the lower two half of the left femur. There's a high signal edema of the surrounding soft tissue. The lesion is infiltrating for the bone. For this features, I will going with osteosarcoma.
Good. I'm just showing you some axial imaging, that extensive periosteal reaction, periosseous, that extraosseous soft tissue, and you can see some post-contrast imaging there as well. So this is the most common malignant primary bone tumor in children, osteosarcoma. And then you have the less common subtypes, and we've mentioned one before, the telangiectatic, etc. These are aggressive metaphyseal and metadiaphyseal lesions. And you saw on the plain film, this is a really nice plain film showing that aggressive periosteal reaction, which you really nicely described. And that the planes actually, particularly on the lateral, you can see distortion of those soft tissue planes and that chaotic appearance of the bone. This is far more aggressive than you would expect to see, particularly the length of the lesion. You can't really see the margins of this lesion at all. This would be very unusual for infection, particularly the location being within the diaphysis. So we have a good example here of an osteosarcoma. I don't know if candidate one wants to have a little bonus attempt at this plain film.
Okay. In this EB radiograph of the pelvis, I see there is left iliac bone cortex showing dense sclerosis with process reaction and soft tissue component. There's a wide zone of transition as ill-defined margin of the lesion infiltrating the left iliac bone. In this region and for this area, I'm going first for Ewing sarcoma would be. How was this? Ewing sarcoma. I see in the MRI study there is big soft tissue mass surrounding the iliac bone lesion, and the iliac bone lesion is extensive in the intramedullary. So this suggestive as big soft tissue mass and the selection. I see suggestive Ewing sarcoma first. Second is suggesting Ewing sarcoma. First, osteosarcoma. Second, osteosarcoma.
Yeah. Yes, it was just another example of an osteosarcoma. It was just a nice plain film. It was in a GP reporting pile. Patient presented with left hip pain, and you can see how much the plain film hides. This is the plain film. This is the abnormality, and how extensive the abnormality is on the MRI. It's terrifying how much the plain film can hide. Candidate 2.
Yeah. Given the frontal and another projection of the left shoulder joint, and can see in the distal end of clavicle and humeral head shows. It's probably the axillary projection. Okay. In the axillary projection, I can see a lytic lesion in the distal end of clavicle and the humeral head, and also in the spine of scapula. But on the frontal projection, I see an increased density overlying the scapular, the glenoid, humeral, and the shoulder joint is not well, this glenohumeral space is not well visualized, and an increased density is seen in that place. More of soft tissue etiology I'm suspecting, and for further comment I would go for a cross-sectional imaging. Looks like an aggressive lesion, probably involving both soft tissue and bone.
What do you do? A CT or an MRI? You said cross-sectional.
MR. Okay, so multiple planes and multiple images in shoulder joint I see. So there is a soft tissue lesion. So the lesion is the soft tissue lesion is enhancing, and it has caused cortical destruction of spine of scapula and humeral head. So this lesion appears heterogeneous and shows some cortex.
So yeah, I mean, you're on the right track. So there is destruction of that.
I have seen a case of chondrosarcoma like this, but I'm not sure.
So this is the second most common primary bone malignancy in children after an osteosarcoma, and actually
the Y view, and it has caused cortical destruction, and I see some pooling of contrast within. The lesion is quite big and involving multiple muscles around. My differentials would be again an Ewing sarcoma. Yeah.
Excellent, good. And part of assessing any bone tumor, particularly Ewing's, what would you be what's the next step? What would you be doing?
Mm.
So you're reporting the X-ray. The X-ray you suggested doing an MRI. You've now done the MRI. What are you suggesting in your MRI report?
PET scan?
No.
For
So referral to a bone tumour centre as number one. You'd want to assess for any metastases. So either a chest X-ray, but most bone tumour centres are suggesting a CT chest to look for lung metastases. So just keeping that in mind, as the radiologist, you're often the person that guides these patients along that management pathway. So being mindful that just spotting the lesion is only where it begins, really. And you had a nice example of this really permeative, destructive mass, and we could see how poorly defined that lesion was, particularly on the plain film. So really a nice description there of the lucency, particularly within the glenoid by candidate 2. And again, you've got this disproportionate soft tissue mass in relation to the extent of bone destruction. So another feature to think about, and we've talked about the chest CT for lung mets. So I feel like we've done a whistle-stop tour through all of the conditions on the slide here today, and hopefully you've seen some examples that will stick in your mind when reviewing plain films particularly, and giving you an idea of some of the sensible differentials to be thinking about. I think it's a really good time for a break. Just want to say well done to candidate 1 and 2 through some very difficult cases that I thought you did really
Okay, so the next part is slightly different. It's really a mixed bag of MSK pathologies, things that I think as pediatric people in terms of MSK, we see quite frequently. So the more common things with a few less common ones, but they all have a point to make, or rather we have a point to make for this, so which is why they're included. So I've got candidates 3 and 4. It doesn't matter. I think let's stick with the 3 first for the first 7 cases, and then candidate 4 for the next 8 cases. Okay, so we have candidate 3. You've got a few MR sequences in front of you. Do you want to talk through this case?
Hello, I'm candidate 3.
Lovely.
This is an MRI images showing soft tissue edema at the right femur and greater trochanteric with muscle edema, soft tissue edema, and involvement of the cortex, which appear ISO on T1 and hyper on T2. And on post-contrast, there is enhancing well-defined collection seen, 2 collections. And can I have a clinical history of the patient, please?
Right leg pain. Right leg pain.
Does he have fever or anything?
Yeah, he's got a fever.
PSR elevated.
CRPs 70, white cell counts 25.
Yeah, findings are suggestive of infectious process like osteomyelitis, and this is most likely an aggressive appearance as infectious like osteomyelitis and abscess.
Okay, so quick question. If I didn't tell you the inflammatory markers, without the inflammatory markers, what would you have thought it was?
Of aggressive lesion, since there is an edema and the cortex be breached, and there is like enhancing collection. So I'll go with osteomyelitis or Ewing sarcoma, aggressive lesion rather than just simple benign lesion.
Okay, thank you. So, well, and this is osteomyelitis. So you've got soft tissue edema. You've got this periosteal elevation. And yes, so this is a T2 fat suppressed, and you can see mirror edema as well here between the greater trochanter and the epiphysis, the metaphysis. And this is apophysis, which is similar to epiphysis, just that it doesn't add to the lengthening of the bones. Okay, so this is apophysis, and this would be the metaphysis, as you normally know in your long bones. Soft tissue edema, that's your that shows you again on a coronal. Now, things to be aware of is in a kid, in osteomyelitis in adults, your T1 is your friend, because focal areas of low T1 signal suggests of a marrow process, which can be infection or malignancy, and it should be lower. So iso or hypo-intense to muscle, which suggests it's a marrow abnormality on T1. But in kids, we've got red marrow, which makes things a bit difficult. So T2 is your friend. And of course, in kids more than adults, infection is one of the top differentials, osteomyelitis, which is why we often give contrast. Now, some people say can do T1 pre-contrast and then post-contrast, but I find that sometimes with the fat, it makes it hard to see. So my preference is a T1 fat set pre-contrast and then a T1 fat set post-contrast. But I think that's down to personal preference. So there shouldn't be, looking at these pictures in my head, there shouldn't be a differential of Ewing sarcoma, because the post-contrast things are the giveaway that looks like an abscess with surrounding enhancement. And a reason why is because this is a cortical breakthrough from the periosteal abscess. Now, osteomyelitis can happen. So we'll just go to the next slide first. So there are different bugs depending on their age. So 6 months to 4 years, you think of Kingella. If you've got sickle cell, you think of Salmonella. Staph aureus is the most common. And of course, if you have any penetrating injury, you think of Pseudomonas. Often you get it in the metaphyses, like what Dr. Kapoor mentioned earlier. Of course, often the long bone metaphyses. Now, bone loss or osteopenia is only seen if you lose 30 to 50% of bone. And so if you have a normal X-ray, as per adults osteomyelitis, it doesn't mean that you don't have it. And so you want to use MR to further characterize what it is. And, like what we said here, periosteal reaction, periosteal abscess, really, soft tissue edema, you can have a joint effusion if it goes into the joint. Okay, or even just a reactive appearance, a reactive phenomena. The only thing here is that bear in mind why it happens in the metaphyses is because you've got the vascular supply, it's very vascular there, and also you can get it in the subperiosteum or subperiosteal region, again, because the periosteum is very vascular. The only caveat is that if you are in a young infant, so if you're in a baby, and also in old adults, where you don't have that barrier, that physes barrier, because in infants, you've got trans-physeal vessels. Okay, so it goes across the physes. So in kids, in infants rather, because those vessels stop after infancy, after a year. So if you have them at a younger age, so infancy, i.e. osteomyelitis, you want to rule out septic arthritis because it can extend from metaphyses through the transphyseal vessels to the epiphysis and then subsequently into the joint space, i.e. septic arthritis. Same process goes into in adults. You don't have that physeal barrier, which is a vascular barrier. It just goes straight through, so osteomyelitis plus minus septic arthritis in adults and in infants. But above the age of 1, you get the nice avascular barrier of the physes, which acts as a protective layer. So your metaphyseal infection, which is often a hematogenous spread, does not go into your epiphysis and subsequently into your joint. However, it can spread transcortically into your subperiosteal space, hence giving you the signs of subperiosteal abscess. Some people say, do you start in the periosteum first or do you start in the metaphyses first? Nobody really knows. It's a chicken and egg situation. So some people only have just purely metaphyseal disease. Some have purely subperiosteal disease, and some have a combination of both. Okay, so that's osteomyelitis. So another example, so this is in a younger child. We can use ultrasound to help us delineate it as well prior to MR, but I personally prefer MR. So, but it can correlate with both even better. So on ultrasound, that's your ossification center of your distal femur. That's your femur, that's your bone, because bone's nice and bright. You've got soft tissue changes on top. You can see it's quite florid and should be nice and smooth, not looking very edematous. And then looking at the soft tissues, the bones here look quite craggy. Okay, so that's the axial or TS view. You've got a little fluid collection here, could represent a soft tissue collection, and there's some erosions going on here. So erosions, you need 2 planes. Unfortunately, I don't have 2 planes here. I've got one plane in the TS, and you should have another one in LS to confirm that it's a erosion. But then we look at it on the X-ray that was done, and in PEDS, we often like to have different modalities to correlate what we are seeing. We get better that way. And you can see that that's very ill-defined distal femoral metaphyses showing these bony erosions of infection. Okay. We've got another one. So septic arthritis of the SI joints, very common in kids. Don't ask me why. And what you're looking for is the characteristic sign. So this is T1. So you can see how that there's a lot of red marrow. So T1 is not really your friend in helping you tell whether there's marrow infiltration. But SEDG stir is quite good. So that's your SI joint here. It's nice and so it's there, nice and straight. And what you have here is just quite a lot of fluid, a high signal within the joint, extends outward into the soft tissues. And then post-contrast, you see these nice little abscesses in the soft tissues, and this is capsular hypertrophy or protrusion, and that's one of the key features to know if there's a SI joint effusion, this capsular bump at the top part of the SI joint. Okay. Next case. Can you read?
Yeah, this is a right shoulder X-ray for a skeletally immature patient. Okay, I'm looking at the bone to check if there is any bone abnormalities. I can see a widening at the space of the right acromioclavicular joint. The right humerus look good. The epiphysis. The ribs, the trunk.
Do you want to ask me?
You can also see the right acromioclavicular joint is like there is widening.
Okay, so what if I tell you that the you can feel a palpable lump or pain at the medial clavicle on the right?
At the medial clavicle at the right. Okay, I might see like an expansion seen at the medial aspect of the clavicle, and however, no cortical disruption or periosteal reaction. Does the patient have anything else like rheumatoid arthritis or known case of anything?
Nope. She tells you she's got right-sided pain, or she presented right-sided pain. Now she also has left-sided pain. So I've got more pictures.
Yes, please. Okay. All right. This is an MRI showing a bone marrow edema at both medial aspect of the clavicle with soft tissue edema surrounding it. And at the right ankle, there is also a bone marrow edema at the physis with lucency, little hypointense lesion seen at the physis with surrounding edema. So it might be due to multifocal osteomyelitis, since the patient have a multifocal site with bone marrow edema, soft tissue edema, and at the physis, which could be due to infectious process.
Yeah, well done. So going back to the first one, so you can see that there's actually expansion of the medial clavicle. You're right. There is no significant bony destruction, but what you have here is periosteal reaction along the medial edge, just underneath here, and possibly along the top. This is smooth periosteal reaction, suggesting this is a fairly chronic process. Because if you, like what Dr. Kapoor said earlier, when you have more aggressive periosteal reaction, the bone has not had time to lay down, so you get partial laying down bones, and then with destruction, so you get Codman's triangle. Can you imagine that the periosteum is trying to lay down, but part of it is just not, because it's being eaten away by whatever destructive process is. So there's smooth periosteal reaction, bony expansion. Now in kids, why is it that you see this? That's because if you think about it, go look back in your textbooks, your acromion ossification center is still cartilaginous, so you don't see that. But in any case, if sometimes you're thinking, oh, is there AC joint dislocation, I think that happens very infrequently in children, and what happens is that you actually get a Vulgent fracture of the distal clavicle, and then subsequent to that you can get a very large periosteal hematoma, making it look a bit like malignancy. Okay, but then MRI will help you clarify it, but just remember your acromion ossification, actually I don't think it starts to form until you're about your 20s or early 20s or late teens. It's why you never see the acromion. Right. So there's MRs here now proving that on the right side you've got abnormal marrow edema. You can't appreciate the periosteal reaction as well, but maybe there's this elevation here and the bottom is a bit well, and also on the left side, so bilateral clavicular involvement in your tibia, and fibula, and there's the fibula because you've got your peroneal tendons running along here. It's a metaphyseal region without the clavicles. You think is this infection, but putting two and two together, you rightly got it as a CRMO. You've got another case here, so same case of CRMO, but different patient, now showing you a more florid reaction in the bone marrow. But again, you can see that it's expansile, it's thickening, cortical thickening, and initially in isolation, we made a mistake of, I called it off, this is malignant because this looks aggressive. However, what happened was that we then did a CT scan, which showed that actually there's actually quite nice smooth periosteal reaction, suggesting that it's more of a chronic process, and because of the clavicular involvement, we are thinking more CRMO. Nowadays, with whole body MR, people use it to see if there are any other sites of asymptomatic disease, and often you're thinking things in the knees and ankles. It's one of those sites, and then you're looking for metaphysis involvement, but often they can cross the physes and be epiphysis as well, as in this case. So this was discussed in bone tumor unit. It's what we normally because initial thought, and given the MR findings, this was more likely to be CRMO. So just a little bit of what it is. So it has a relapsing remitting course. Of course, it's not non-pyogenic. Well, they say non-pyogenic because it's not. There's no bacterial growth. Typically multifocal, but patients can still have systemic features of like fever. So it's like a systemic JIA picture. It is more common if you are at higher risk if you do have some underlying inflammatory disease. So good for your question of is there any underlying JIA. You get multiple sites involved, and I said earlier, long bone metaphyses or metaphysis equivalents, and it's the most common disease to involve your medial clavicle. In the adults, you think of cepho, which comes with pustulosis and skin changes as well. And of course, like anything, when it's acute, it can be lytic, and then later as it starts to heal, you get that adjacent sclerosis, and of course, if it comes back again, you can have new lytic areas. So it's a waxing, waning course of disease, and use a whole body MR to screen. And if you've got multifocal disease, then it's more likely to be CRMO. But of course, you need to think about things like metastases, because if you've got a primary cancer, then of course, it can be, you correlate with clinical history, any weight loss, any systemic symptoms, how the blood markers. Sometimes you even do a abdominal ultrasound just to screen your normal things like Wilms tumor, neuroblastoma, and so on. A blood film to just make sure there's no evidence of leukemia. Okay. Right. Another case.
Okay, this is an MRI T1 and T2 fat SAT for the left hip, showing surrounding joint effusion at the left side. This effusion surrounding the left femur. However, there is no definite bone marrow edema. At the acetabulum, there is mild breaching of the cortex seen. However, no bony lesion is seen. I'll think of septic arthritis, since there is a large joint effusion with no significant underlying cause of a bone lesion or anything to cause it.
Okay. So you've got more information. You go back to previous history and you see other findings within the patient's packet that the clinicians haven't told you about. What do you think?
There's a wrist X-ray for skeletally immature patient showing like the generalized osteopenia at the X-ray with multiple subchondral cysts. However, no definite bone fracture or bone lesion could be seen. There is some kind of ankylosis. I'm not sure about it at the carpal bones. At the MRI, there is a joint effusion with multiple bone marrow edema at the carpal bones and at the styloid process of the ulna. There is erosion also and like soft tissue with multiple subchondral cysts. And on ultrasound, there is fluid with echogenic material, not clear fluid, with like debris. So I'm thinking of a systemic disease, maybe rheumatoid arthritis, since it's affecting the carpal bones.
Okay, and in good. And if you're thinking of an inflammatory arthritis in kids, is it called rheumatoid?
Juvenile rheumatoid arthritis, it's occur more with ankylosis. the juvenile rheumatoid arthritis.
Yep. Okay. Good. So well done. So MRI of the hip, T1 and T2 stir, and nicely picked up. There's a large joint effusion on the left, not on the right, as in there's always going to be a little bit of joint fluid that's within normal limits. What's interesting is that these presence of this synovial proliferation, almost looking like, very quite rice bodies like. It's just the appearance of it. Of course, we often think of it in something chronic, so like chronic TB, TB, RA. The interesting thing here is there's not much in the way of meridema, and if this was, of course, correlative clinical history, although sometimes it can be hard because, as I said, systemic JIA can have fever and raise ESR, CRP and stuff. But septic arthritis is going to be really painful, often acute flare of JIA or juvenile idiopathic juvenile inflammatory arthritis. People can still go on. They can still carry on. They are not in excruciating pain. So it can be grumbling for quite a while, and then it's incidentally picked up. So it's this synovial proliferation that's quite marked, and the absence of meridema. Often in septic arthritis, there will be some extent of meridema, and of course, prolonging it without treatment, you start to get more in the way of bony destruction. Yeah, because of the inflammatory process. Now, in small thing, so we do MRI of the hip. We also look for other features. In this T2, there's probably irregularity of the chondral surface. It's probably just an incidental osteochondral lesion that's not associated with the underlying process. On the other X-rays, so what you can see here, nicely picked up, is that you've got, I guess it takes time to get your iron, but if you look at quite a few wrist X-rays of the same age, you notice that there will be a bit more joint space between the proximal carpal row. Distal carpal row still looks okay. This the mid carpal row. The space is quite narrowed. It's called a bit of carpal crowding. There's also sclerosis. It doesn't look very happy in the proximal carpal row. On the left and on the right, you can see it's actually, there is a widening of the scapholunate. You've got decrease, you've got the subluxation of the capitate, all looking a lot like what you think in rheumatoid arthritis if it was in an adult. Similarly, the changes on MR shows the bilateral joint effusion. All these little cystic-like appearances could be subchondral cysts. Could be represent erosions more than subchondral cysts. Probably not really erosion given the extent of disease. Now, on ultrasound, this is your classic view of your wrist joint, the radial carpal joint in the midline of your wrist, and the black bit shows synovial thickening. The only bit that I didn't give you was the Doppler, which would show a vascularity, suggesting it's active synovitis. So in rheumatoid, or rather in arthritis in a child, you can get, if you just had treatment, you can have a lack of the Doppler vascularity, but you still have synovial thickening persisting for a bit until the treatment starts to kick in. But you can just notice that on the right side, it is a lot worse than the left, which corresponds with what the patient's symptoms are. Okay. So JIA, juvenile idiopathic arthritis. Apologies, I always use JIA, so I don't really think about what the full name is. So there are different subtypes. They are, of course, beginning before 16 years old. We are not going to the different subtypes here, but you just got to realize that they can be monoarticular, polyarticular, it can be oligolar articular, enthesitis related, so something looking like ankylosing spondylitis, so different types. But technically, all you're looking for is inflammation, joint inflammation. Carpus, your carpal bones, the most site of fusion, the earliest sign is carpal crowding. You don't really get the fingers, you don't really get erosions in the fingers, I'm not sure why, but often affects large joints, your wrists, your knees, your hips, your ankles. Okay, and of course with hyperemia, you can get very long gracile bones because of the hyperemia, balloon or enlargement of the epiphysis and your intercondylar notches. And if you think of enlarged intercondylar notches, the thing you think of is hemophilic arthropathy. Again, same process. You keep bleeding to the joint. You get constant inflammation causing hyperemia causing your bone changes. Same thing. Okay, but easy to think is that whether it's their family history of hemophilia, a simple test to just make sure that the screen. So just some things to show you the difference. So patient, both legs, one has more affected with arthritis on the left and not on the right. You can see the epiphysis is a lot bigger on the distal femur and the epiphysis as well. And then this is one that has a bilateral JIA involvement of both knees. And you can see that widening of the intercondylar notch. To be fair, I think it's hard to, if you are just looking at asymmetry, if you're looking at symmetrical both sides without one to compare, then in the absence of other symptoms and purely isolated widened intercondylar notch, I think it's hard to pick up. Okay, and I often have to go back to compare it with age-matched controls to say, is it truly widened or is it just a projection thing? Patient has these long gracile bones flaring of the metaphyses and epiphysis with osteopenia, erosions, and all of this, in the joint space narrowing. So remember, in inflammatory pathologies, even in kids, your joint space narrowing is diffuse because if it's coated by synovium, that's inflamed, versus in an older patient where osteoarthritis is quite focal because it's in the weight-bearing aspects. Okay, so inflammatory diseases affecting the joints often give you diffuse joint space narrowing and not focal. Okay. Right, now the other thing that's quite common in kids, we see Baker cysts, or rather fluid within the semi-membranosus medial gastrocnemius tendons, the bursa. It's a space, and we often see a Baker cyst. A Baker cyst is idiopathic, but you can also think, is there something driving fluid production, causing it to leak out into the bursa, because it often communicates with joint. You do see it in ages from 2 to 14. And the different thing here is that we always need to make sure on the MR, if you see a Baker cyst or even an ultrasound, make sure there's no underlying cause like an inflammatory arthritis or something else that's driving it. And 2 different patients, and you can see that on this one, you've got synovial thickening, and synovium is based on MR on T2, is these low signal frond-like bits that coats the joint capsule, the space, the joint space, and that's that's basically a inflammatory process driving this Baker cyst production versus one that has mostly joint fluid within the Baker cyst, but none really in the joint space, and no evidence of synovitis. So I think this is just to let you know that if you do have a Baker cyst, although it's reported, just make sure that there's nothing else underlying that's driving it. Okay, next type of case. How are we? So, okay, yeah, continue, candidate 3.
This is a pelvis X-ray for a skeletally immature patient. This pelvic X-ray. Okay. What's the history? What the patient complaining of?
Altered gait.
Okay.
This was a family history. Patient was first born born in a breech presentation.
Yes. Okay. I will check if there is any signs of DDH for hip dislocation. As I can see at the right side, there is mild disruption of the Shenton line, and the femoral head epiphysis is slightly smaller, asymmetrical. I want to see the Herglen line, and if the femoral head is within 2/3 medially, and if there is soft tissue swelling or elevation. It's a bit tilted, the pelvic X-ray, not well centralized. However, I would raise the suspicion of right-sided DDH.
Yep, well done. Yep, correct. So all the key salient features are mentioned. So Shenton's line, we'll go through that, but this is the left. So the left is the normal one, the right is the abnormal one. It's nice line drawing from the obturator foramen all the way down. Makes a nice smooth curve. You can argue that this is not quite smooth. You can see one line here and then another line here. So there's disruption of Shenton's line. There is asymmetry of the femoral epiphysis. One side smaller, one side bigger. The other thing that to look for is that if you draw lines, which I'll show you on the next slide, you draw a line through this. I believe this is the Perkins line. I always get those confused, but essentially a line through the triradiate cartilage, another 90 degrees done along the lateral aspect of acetabulum. So if you draw one here, okay, and draw one here, this should be in the lower inner quadrant, and this is kind of a bit more laterally positioned. So there is a subluxation of the hip. other small things you can think of is an acetabular angle. Okay, you can draw one here. So using this, I think it's Perkins line. And then you do the angle between here and here, and then the angle between here and here. Okay, so this is a steeper angle, and this is a bit more, yeah, so this is a steeper angle than this. Just remember, as you age, this bit line should come down. Okay, so just making it flatter. But this is it's a slightly larger angle. Okay. So next slide shows you all the key features, and now you've got a left-sided DDH because this femoral head should be in here. Okay, so my history wasn't the best because essentially if she had breech presentation, if she had family history, if she was firstborn, these are key risk factors of highly suspicious of DDH, and all of them under the NIPI guidelines, neonatal hip screening guidelines. Can't remember the full term. In the UK, they would be subjected to an ultrasound within the first 4 to 6 weeks. Okay, so these, so essentially, if we had missed her, that's because either she missed an appointment or there was something else. So technically, a lot of babies are now early DJs picked up early. They can put in a Pavlik harness and monitored with time so that it can be corrected without surgical intervention. Okay, so that's that. Now, DDH, just a little bit of DDH, the reason why we do it as early as possible, so 4 to 6 weeks, and then we can monitor them up to about 4 to 6 months. That's because of the ossification center. So when you do I have no pictures to show you of the ultrasound, but you know, there are a lot of techniques out there. The most commonly known as the graph technique for ultrasound. You can look it up on YouTube or on a book. And they do it, they say less than 4 months. That's because when you start to have ossification of your femoral head, it makes it hard because the calcification or the ossification blocks your sound waves passing through, so you can't actually see the positioning so well. So 4 months because that's when your ossification center has not yet formed, and it forms after that. Some people push it to 6 months because everybody ossifies at a different age, but I'll say no later than 6 months. Okay, so by 9 years old, by 9 months and onwards, you are really using X-rays to help you to ensure or to characterize if your hip joints are in place or not. Okay. All right, next case.
This is a pelvic X-ray for a skeletally immature patient, showing at the left hip there is a widening of the joint space and decreasing of the left femoral head epiphysis, decreased in size and increased in density, shows sclerosis. The growth plates appear good, so findings are most likely suggestive of Perthes disease, AVN of the left femoral head epiphysis, due to decreased and collapsed of the left femoral head epiphysis and widening of the joint space, which is joint effusion is the early sign.
Okay, good. Well, you've got another MR, so we did MR on this child. Do you want to talk me through this? Does it confirm or refute what you initially thought it was on X-ray? Candidate 3? Do we just lose you? Hello? Co-host, have I done something wrong? Candidate 3 has disappeared. Candidate 3? Okay, if you're not back in the next 5 seconds, we'll probably move on to candidate 4. Hang on, let's see what's going on. It's an internet problem. Okay. So sorry to put candidate 4 in a spot. Candidate 4, do you want to take over? You can start. Whether you agree or disagree, you can start from the previous slide.
The X-ray is showing that the left femoral head is sclerotic and deformed. The rest of the bones appear normal, so This could be avascular necrosis of the left femoral head.
Okay. And then how about the MR?
On the MR, I see that there is the left femoral head. There is a T2 hyperintense area with surrounding edema. There is also a hypointense line on T1. So this is, yeah, this.
Are you changing your diagnosis? Are you adding more to your diagnosis, or are you keeping with the same diagnosis?
No, I want to change the diagnosis because this doesn't look to be avascular necrosis. This looks to be a T2 hyperintense area in the in the neck of the femur with surrounding edema. So, T1 hypo, T2 hypo.
Okay.
I'm not sure what's this.
Do you want to hazard? Just say something, anything that comes to your head, as in any different shows at all. No judging here.
T2 hyperintense with edema in the epiphysis would be like a blastoma.
Okay, cool. All right, so same MRI. We're going back to the X-ray first. So as what everyone has mentioned, there is flattening, there's sclerosis of the femoral epiphysis. There is some lucency here. Okay, it's not there. Okay, on the other side, and essentially the hip is still enjoined. There's no slip at all. And when you look on the MRI, so that's T1, T2, and post-contrast, there is that lucency corresponds to this low T1 or isointense T1, high T2 lesion within the metaphyses with a little of a contrast enhancement. Some joint fluid, but not much in the way of synovial thickening, because all of these probably just be of joint capsule. So this is a trick question, and I think it also tricked us all. The only thing here was that we did raise a possibility of infection just because it was at the metaphyses. You've got all these marrow signal change as well. However, this is on the background of Perthes disease or avascular necrosis of the femoral head epiphysis. The only caveat to this was that the patient was very, very well. Okay, there's no systemic features of infection at all. And so what we have is that that's actually cystic metaphysal changes. So as I said earlier, so this is Perthes disease where you have flattening of the femoral epiphysis, and on imaging you get sclerosis, fragmentation, flattening, and then you have these cystic metaphysal changes, and with time you get enlargement of the femoral head, you get flattening, you get a very short neck or coxa brevis, and then you've got this and you can get femoral head extrusion, FAI, labral tears, everything consequent to that. Your peak age is always about 4 to 8, so often it is above that of transient synovitis as a cause for a limp or hip pain. So it's older than transient synovitis because that's kind of below 3, and it's younger than your Sufis, which is really in your adolescent age. Okay, so your Perthes or AVN of the femoral head is kind of the one that's in between. Now, coming to the metaphysis, metaphyseal cysts, so we see earlier. So they are really, so these ones here, people don't really know what it's due to. There are some theories that they could be due to because you've got growth plate disturbances, because you've got the femoral head necrosis. So these tongues of physeal cartilage that have like protruded into it, and because of the changes in blood supply, these are areas of unossified cartilage which have persisted, so causing these cystic-like appearances. Or is it fragmentation of the trabecular bone? Is it some deposition of fibrous or fibrofatty tissue or granulation tissue because of whatever that altered blood flow that's within the hip joint? The cool thing is these are actually not very rare, and in literature it's reported that they are seen in a delayed phase of Perthes disease. So it could actually help you to actually say this is Perthes disease, okay, to be quite confident. But of course, I say take a pinch of salt, always correlated with the clinical history. What does it tell you? Yeah, so Perthes, you can also get spontaneous revascularization, so the disease can hold on its own. As I said, nobody really knows why Perthes happen. In an older person, so in an adult, if you've got avascular necrosis of the femoral head, you think steroids, you think alcohol, pregnancy, stuff like that. But in kids, it's really idiopathic, nobody knows. disruption of blood supply, probably, or alteration to the blood supply. And so here we see in the first stage, you get this collapse and sclerosis, like what we saw in the metaphyseal lucency. These pictures are from radiology assistant, which demonstrates it nicely. And then you've got progression to fragmentation and development of very short, broad column, the coxa brevis, if I'm not wrong. And then finally, you get this coxa magna deformity. Okay, so that's, and of course, when you see that, you always have to think, is this secondary avascular necrosis? If the patient has had radiotherapy or chemotherapy because of leukemia, lymphoma, is this something like a multiple epiphyseal dysplasia, but you can see the progression? And the other thing is Meyer's dysplasia. Okay, now, Perthes, we take it out, is really avascular necrosis, or you can think of it as an osteochondritis desiccant or osteonecrosis. So the next few slides, I'm just going to show you different how it can, so Perthes-like diseases, but in other areas of the bones of the body. And so if you take away Perthes and think of it as an osteonecrosis syndrome or osteonecrosis pathology, then that makes then that helps with the next few slides. So if you don't get in the hip and you get it in the elbow at the capitulum, because that's your radius. At the elbow, you can call it an osteochondral lesion, osteochondral defect, and this one is a defect because you can see that there's actually breakage or fracture of the osteochondral junction, and there's also a free fragment here. So people say you can differentiate between Pennier's disease. If Pennier's disease is just osteochondritis desiccans or osteonecrosis, but without floating fragments, and something a bit more, you can call it an osteochondral defect. Is what this one is. Okay, so osteochondral lesions are just ulcerations within the osteochondral junction, but you don't have this floating fragment. So I leave the floating fragments for osteochondral defects. And I think it's easier to kind of describe it rather than to put the eponymous names on it. Okay, so I think we've mentioned a lot of this. So people don't know, was it due to genetics, repetitive stress, ischemia, some combination? So osteochondritis desiccans, some called chronic osteochondral injury, and then fracture or defect, as I call it. And I think the important thing to take away here is that you are looking for features of an unstable lesion. It can happen in the knee, it can happen in the elbow, and you're looking for that fluid signal or cystic changes around the fragment, of course, a free-floating fragment within the intra-articular body, and your discontinuous overlying articular cartilage. Okay. Other areas of osteochondritis, which you might know, so metatarsal hits, Fibrous, the navicular, there is a name for it, I can't remember, Colas, at the base of your metatarsal, fifth metatarsal called isolins, but just remember it can be a chronic traction injury, so similar, or fracture or apophysis. So this one's a hard one. And things to look out for is whether you've got soft tissue swelling, whether the patient's asymptomatic, because this could also be a normal apophysis site. Don't confuse that. So apophysis are always vertical, fractures are transverse, lucencies are transverse, and you've got stress fracture, Jones fracture, Valjean fractures, but essentially if there's a fracture there, you call it transverse lucency. And of course, you get Sever's disease, which is fragmentation and sclerosis of the calcaneal apophysis. Things to note is that you've got a lot of normal variants that can look like that, similar to the apophysis here. So if you see sclerosis, don't always call it Sever's disease. Just make sure that patients, just correlate with patient's symptoms. Okay, because normal apophysis can also look like this. Okay, candidate 4, you continue. So next case.
I'm candidate 3. I'm back.
Okay. Yeah, if you do this case, this will probably be your last case. Okay, well, I can give you another case. It's no problem. Yeah, please continue.
Okay, this is a pelvic X-ray for a skeletally immature patient, and showing widening in the growth plate at the left hip, and the left femoral head epiphysis. It's showing it's posterior medial, where there is a disruption. If I draw the Kellen line, it's not crossing the femoral head, and it's more prominent on the frog view. So findings are suggestive of SCAFI, stepped capital femoral epiphysis at the left femoral head, where there is widening in the growth plate, and the left femoral head epiphysis, it's moving posterior medially, and it's not intersecting the Killen line.
Okay, so you've got another MRI that was done. Does it confirm or refute the diagnosis?
Yes, it confirms there's the femoral head epiphysis. It's subluxed posterior-medially with joint effusion, and findings are suggestive of split capital femoral epiphysis.
Yeah, good. So exactly what you've said. So there's asymmetry of the physeal line. So you've got widening, your sclerosis, and most importantly, you've got the slip, which is best identified on the front lateral view. You talked about Klein's line. We'll talk about that in a bit. So that's slipped. And then if we look at the next slide, which is the MRI, you can see the slip quite nicely with adjacent meroedema. Key one's best to see the physeal widening, you can see here, compared to this nice and thin black line. And with reactive edema, important thing to note is that there's no slip on the other side, because you can get one slip can herald another slip. And I can't remember what percentage of it is bilateral. It might be in the next slide. Yep, so 18 to 80%. Often we call it a Salter 1 Harris fracture because it's through the physeal growth plate or the physis. And there are chronic stress or weight bearing. Often it's people or in children who are a bit bigger, higher BMI. And I find the asymmetry of the physis one of my more sensitive markers, because early slips you may not be able to actually see the slip, but front leg lateral would be the more sensitive view to then the AP view to look for the slip. And if still in doubt, then do an MRI, because what you're looking for is that physeal elongation on T1, as I mentioned earlier, that meroedema, and of course synovitis. And MR can help you also to identify other lesions which may not have picked up to cause pain. So you mentioned the Klein's line. Now I don't think the Klein's line is used in a front lateral view. Off the top of my head, I thought it was only in the AP, and certainly I've only used it in the AP. So you're abnormal. So you're basically drawing along the lateral aspect of your femoral neck, just along a parallel line, and you should see your femoral head protruding beyond the line. If there's a discrepancy of more than 2 millimeters between both sides, then you call it abnormal. On the side that you don't see the femoral head protrusion over the line. Okay, so that's your Klein's line. Okay, candidate 3, maybe last case for you, and then we'll move on to the other guy, to the other candidate. Sorry.
Okay, this is pelvic X-ray. At the pelvic X-ray, I can see at the right iliac bone there is like periosteal reaction. There's a small fragment. It might be there's a vulgin fracture. And the MRI it shows there's bone marrow edema and soft tissue edema with cortical disruption at the right anterior superior iliac spine. So I think findings are suggestive of a vulgin fracture of the right anterior superior iliac spine, where it's the insertion of the sartorius, I think. Yes.
Yeah.
So it's a vulgin fracture.
Sorry?
It's a vulgin fracture.
Yeah, that's right. That's right. So a vulgin fracture, you can see, is an older child. The growth plates are almost fused. And main things to note is that in kids, you need to know all your sites of potential vulgin fracture. And what you look for is the asymmetry between one side and the other side, making sure it's a properly centered radiograph. And this one it was, but I think the orthopedic surgeons just wanted further clarification on how it looks like, and hence we got a nice image for teaching. And I think on first impression, had you not seen the if you just saw this in isolation without the X-ray, you can think, is this something a bit more worrying because of the meroedema, because of the soft tissue swelling? Can it be something a bit more sinister like sarcoma? But then seeing the X-ray is very reassuring, and of course seeing the axial showing that cortical disruption. So that's your cortex and it's kind of fallen off, and with hematoma and callus formation and healing. So it can be due to a single repetitive trauma, your disruption of the tendon or bone. Often it's 15 to 25 years of age, sports person. But if you think in an adult, if you get a vulgin fracture, often in the lesser trochanter, you're thinking of something like a pathologic or insufficiency fracture. So I think that's the key thing here. avulsion fractures, usually thin crescentic bone fragment, distracted, maybe, or just a very faint one, and you get very exuberant callus formation. So it's important to just to look at the plain films, because it will give you quite a lot of answers, or going back to initial, or finding out the history of what happened. Was there a pop sounding, or was there some spots involved? So history is quite important here. So common avulsion fracture sites on this. I think everybody should know this, anyways. So I wouldn't hang on too long. Similar diagnosis, different case. Can you tell me where the site of injury is?
It's avulsion fracture at the insertion of the ACL at the tibial spine. Tibial spine. Yes.
Yeah. So this is quite a satisfying one when you're seeing in your trauma pile, because you can see it quite nicely. The tibial spine is irregular. There will be quite a bit of soft tissue swelling. There'll be a twisting or mechanism of injury. And then often you say, if there's a lot of joint effusion, you see that, you just want to make sure that you do an MR. It depends on what the orthopedic surgeons want. Sometimes they say, actually, no, it will heal on its own. But often they will say, just do an MR to ensure there's no other internal joint derangement. So an MR shows you nicely that it is avulsed from the foot plate of the distal ACL attachment. The ACL fibers still look like they're quite continuous. Sometimes they can look a little bit irregular, mainly because they are no longer taut. Okay, but then just make sure you look for it carefully and correlate it on not just your sagittal but also your coronal. See that you can follow those fibers through the bundles. So avulsion fractures, common injury. And you can also do a CT scan. Often you don't need to if your X-ray can see a displaced fragment, but sometimes if it's undisplaced and very subtle, it can be easily missed unless there was, as I said, a free-floating fragment. So it's very common in boys 18 to 14 years old. And radiographs can identify most avulsion injuries. A small cortical avulsion can be very hard to see, so which is why you MR to look for it, because you are looking for bone marrow edema, and also look for other associated ligamental injuries. You don't have to avulse. You can avulse the insertion. You can also sometimes avulse from the tibial tuberosity and then extending through the physis as well. So many different types of avulsion fractures. So just a graph, or rather a pictorial representation of common sites. There is some overlap with adults as well. So your A and B is your ACL, D and E is your PCL. You've got your LCL, capsular ligaments kind of here. You've got arcuate ligaments, so your Sagon fractures, reverse Sagon, deep meniscal tibial ligaments. You've got your arcuate sign, so part of your posterior lateral corner. You've got your conjoint tendons, so a combination of LCL and biceps tendon insertions. Okay, there's the proximal attachment. Similarly on sagittal, so similar sites. Okay, so these are common sites of avulsion. There is a very nice paper called Pediatric Avulsion Fractures in the Knee. If anyone's interested, you can have a look in that. Okay, next case. Let's go with candidate 4 now, please.
Okay, thank you so much.
Oh, thank you. Well done. Candidate 4.
This is a frontal radiograph of the pelvis with a single view of the right hip.
Yep.
I'm looking at the bones. There is an avulsion fracture of the left lesser trochanter of the femur. The rest of the bones appear normal.
Okay.
The tissues appear normal.
Okay. If I tell you that the pain's not at the lesser trochanter, but more along the femoral shaft, see any?
Periosteal reactions.
Yeah, exactly. Okay, so you're right. Okay, there is periosteal reaction, so it's quite thin. You can almost say, is it lamellated? But then when you look at it on the other one, not so convincing. I would say it's more convincing here. Okay. Now then you decide to do a bit more because you're like, the soft tissues are quite okay. I'm not sure the bone density is okay. Let's do more imaging. So you've done more imaging.
This is coronal T1 post-contrast MRI. Then axial T1 and axial T1 fat saturation. I see that in the right femoral shaft, proximal diaphysis, there is a enhancing area at this region of periosteal reaction. Then there's no cortical break, there's no adjacent soft tissue mass. So this, if the patient has raised inflammatory markers, this could represent osteomyelitis or
pain. Patient's quite a keen sports person, runs fastest in her school. No, not unwell, no fever, inflammatory markers are all okay. Does it change what you're thinking of?
Then it could be a stress reaction.
Okay. Anything else?
No, I can't think.
Okay, so are you quite confident? Are you gonna tell them that's it? We're gonna leave it alone. We're not gonna do anything more, or are you gonna say, I want to do more stuff? You can choose to repeat imaging. You can choose to do another scan, a different modality. What will you do next?
I would like to do a CT scan of this.
Yeah.
So on this axial and coronal CT scan, I see that there is a diffuse cortical thickening seen in this proximal femoral diaphysis, having a bone within bone type of appearance.
Mm-hmm.
So this could represent congenital conditions like osteopetrosis or infections.
Would osteopetrosis just affect a single bone in a single site?
More systemic, multi-system.
Think about one of your differentials you mentioned earlier. And remember, it probably took some delay because patients clinicians didn't want an urgent CT scan. They said, oh, do it when the next available. So you're going about some time in between the MR and the CT, maybe a week or 2 weeks. 2 week wait, so 2 weeks.
So there is a tract communicating to the superficial. So this could be a osteomyelitis.
Okay, so fine. I see where your point. So I see where you're going with the. Let me just go back to with that. So I think we mentioned about the periosteal reaction here. Not much in the way of lytic or bony destruction or osteopenia. I mean, the bone densities look quite similar apart from that that periosteal reaction that we can see. So on MR, these are just, if I'm not wrong, these are actually just T2 stir sequences, fat suppressed sequences. There's no contrast here. This T1, so rightly pointed out, there is the area of marrow abnormality in there, which hypo or isointense on T1, hyperintense on T2, with probably a bit of periosteal inflammation medially. And you can see there a bit of soft tissue. But otherwise, no soft tissue mass, okay? And then on the CT, the same cortical thickening, and you've got this little area of lucency here. I see where you're coming from. You're thinking it's a tract, but if I say it was osteomyelitis, then you'd be expecting a bit more, I think, sclerosis, and certainly some soft tissue changes, which we're not really seeing that florid on the MR. Also thinking of I did say it was periosteal location, but often you would also get it, it will move somewhere. It often starts metaphyses, then going subperiosteal. I think that's the more common distribution lucency here, and this was thought to be a stress fracture. Okay, so certainly because of the initial appearance, this was discussed in the bone center unit, and given the patient's really well, this was considered a stress fracture. Now, the other thing was that, is this a stress fracture from an underlying pathology? So she had a whole body MR, and counting for the weight in between all the that meridema had actually improved, and she had no other lesions elsewhere. So this was treated as a stress fracture. So stress fractures, in kids, you often see in the tibia, you think of shin splints, often the sports person. It's true, a femoral region is a slightly more rare one, but still can happen. And on X-ray, it can be quite subtle. I mean, I think you need to, all the other things you're thinking about, infection, even osteoma, it's a very important differentials. And MR would help you to delineate the extent of in marrow involvement, and then if you're still in doubt, do a CT for characterization. I think in kids, if you don't find the answer with a single modality and you think that it could be certain other differentials, consider their CT. Although there's radiation, it can help you to narrow down your differentials. I'm not saying to do it in every one you don't have answer for MRI, but if you have an answer and you have a potential differentials, some of which can be excluded on CT, like osteoma, do it. Okay. Now, if we just talked about marrow signal changes, I think one of my ex-bosses used to tell me a very good thing. So if you just see marrow edema on MR without anything else, you think of three things. One is osteoma, which you can't see the nidus because the nidus is better seen on CT. You think of a stress fracture, and the third thing you think of is early infection. Okay. Right. Other examples of past, stress-related changes or stress-related injuries is past defect. Here in kids, not always, you get the slippage or the listhesis, the enterolysthesis. You know why, because this thing sticks to here, and then you've got the two bits acting like hinges, so protecting this from slipping forward. When you've got the fracture there, if it's bilateral in particular, then you've lose that little grip between the bone edges, so this whole thing slips forward. That's why I've got an enterolysthesis of the upper vertebrae on relative to the lower vertebrae. Okay, it can be chronic, it can be acute on chronic. Yeah, actually, yeah, it's usually it can be chronic or acute, and then your MRI, of course, if it's acute, you see more meridema, soft tissue changes. If it's more chronic, because something had happened and then things have changed, then you see less of the soft tissue inflammation surrounding it. So often you see in gymnasts or sports which needs a lot of hyperextension, like baseball throwing. Yeah, so past event. Okay, next case. This is a difficult case. So you can ask me questions, or I might give you hints. So we've got a series of studies. It's a story case, okay? So have a look at the first X-ray. Tell me what you see. Just tell me what you see, but don't give me a differential first. Then I'll show you other images.
This is frontal auricular frog-leg view of the pelvis. I can see that there is a irregular lucent area in the right femoral neck in intertrochanteric region and proximal shaft. There is suggestion of some morphotic appearance, suggestive of an aggressive pattern. There is no pathological break. There is no extraosseous soft tissue. So this could represent Ewing sarcoma or lymphoma.
Sorry, candidate 4. Are you looking at the left or the right?
The right.
The right hip. Is it right? Are you looking at the right hip?
Yes.
Okay. And are you talking about some abnormalities in this region here?
A little caudal to that, a little lower.
Lower, here.
Above, I think subtrochanteric region, yes.
Okay, okay. Okay, so you think there's a malignant process going on here, okay. What do you think of this?
There's a periosteal reaction, lamellated type of periosteal reaction in the visualized femur.
Okay. And then how about the left hip or the left leg?
This is the left leg. Okay, there's a fracture of the left femur, which is an old fracture because there are corticated margins along with the periosteal reaction, and there's evidence of a soft tissue around that. So this could be a pathological fracture on the left side.
Okay. Anything else to add?
So sparing the epiphysis involving the diaphysis predominantly.
Okay, don't worry. We'll go on to the next one.
So this is an ultrasound. So this is an MRI T1, coronal, sagittal and axial, showing a large T1 iso-intense mass lesion arising in the right renal, right paravertebral region with with extension through the neural foramen. So this could represent a neuroblastoma.
Good. Okay. Yeah. Okay. So this is just quick note. This is June 2019. Okay. So 1 year down the line. This is June 2018. So 1 year before, which is right. Patient is young. This was about 1 year of age with neuroblastoma. Okay. And then he was treated. This June, yeah, he was treated quite quickly, and then of course, and in May 2019, so 1 month before your initial X-ray, this is how his MRI spine looked like.
Sagittal MRI of the cervical spine and of the thoracolumbar spine. On the cervical spine, there's no intramedullary lesion within the spinal cord. Surrounding CSF spaces are fine.
Do you still see, I know I only given you a slides, but on the right hand side of the lumbar spine or lower spine, do you see that a big lesion anymore? Patient has aggressive treatment. They've given him, I can't remember what they give to treat neuroblastomas, but essentially they gave him the all clear.
There is a residual small lesion seen in the mid-lumbar region.
Yeah, possibly this you're looking at. Okay. So are you still going with pathological fractures? Sorry, it's a difficult case. Essentially, what I was just trying to show you was on the line of insufficient fractures. I mean, I like the fact that you thought, so let's go back to what you said. there is no metaphyseal lesion here. Yes, there's a little bit of irregularity here. I just wonder whether it's due to its position or whether this could be some sort of heterotopic ossification from some other cause. But metaphysis is clean, your epiphysis is clean. I think the diaphysis is probably a bit projectional because you can see it, he's not quite centered, it's a bit rotated. He has periosteal reaction on the right side, and it's confirmed on the long leg views. And on the left side, yes, it's probably a more chronic fracture with periosteal reaction and signs of healing. It's undisplaced. It's displaced and quite separate from each other, which is why it's probably trying to heal but cannot heal. You can see all that soft tissue edema and soft tissue swelling because of the density of the soft tissues. Okay, so something's going on wrong here. So the reason why I've showed you this, because this is actually a type of insufficiency fracture. Now, you wouldn't be able to tell it from the first instance. All you can say is that there is a displaced fracture on the left and periosteal reaction suggestive of a fracture, but an underlying soft tissue, a bony process, malignancy cannot be excluded. Do an MRI to characterize, but I think on the other view, which I may not have shown, there was a cortical fracture with evidence of healing. So this just shows you that when you see neuroblastoma, first thing you think of is bone mets causing pathological fracture. I think the next image that I show you is that patient's been treated. You see, this is your cord. The cord's essentially because of radiotherapy. I think the guy had radiotherapy. You've got long-standing, Malasic changes. So patient's actually paraplegic, okay, because of the treatment. And subsequent to that, he's developed disuse osteopenia, and that those are actually insufficiency rather than pathological fractures. But pathological fractures, given the history, would also be reasonable. Okay, so we know the difference between insufficiency, so it's physiologic stress on abnormal bone in this case, so osteopenia, disuse. And according to Wolff's law, your bone's constantly remodeling. So if you give it stresses, then it will continue to lay down new bone and become stronger. And if you don't use it, it will start to waste away. A stress fracture is one that we saw earlier. So it's abnormal stress, like overworking it on otherwise normal bone. You're not giving the bone and microtrabecular changes time to heal. And I always leave pathological fracture for something that's weakened by tumor, so like a metastasis, pathological fracture. You can argue, some of the bone tumors that Dr. Kapoor had mentioned earlier. If there was a fracture, you can still call it pathological because there is a tumor process within there. So many causes. This is more from the adult population. You can get insufficient fractures from lots of things. I think in kids, you are thinking more of the previously irradiated bone because, radiotherapy is quite common in the pediatric cancers. Okay, next case. So I will give you a history. While running, fell over and twisted ankle.
So frontal and lateral radiograph of the ankle joint. The fibula and tibia are seen. They are both normal. The talus is fine. The rest of the carpal bones, the phalanges are fine. Looking at the calcaneum, on the superior aspect of the calcaneum, okay, no, that's unfused apophysis. I cannot see any fracture or dislocation on this view.
So painful swollen ankle.
There is some soft tissue swelling around the ankle joint.
Any joint effusions?
Oh, yes, there is some soft tissue swelling, could be a joint effusion. I would suggest an MRI for the evaluation.
Yeah. So I think it's a point just to make that just when you're reporting pediatric films, just take a close look at drawing all the contours. So, and anything, any lucencies, you should be able to define it. And if you can't, look at Keats first to make sure it's not a normal variant. And then after that, you can explore the other differentials. So there is soft tissue swelling, okay? Certainly on the lateral aspect, maybe you can say a little bit on the medial, just cause it, to my eye, they look a little bit more full than compared to normal or normal fat. But there's definitely more on the lateral side and medial side. So I usually took a kind of like an eyeball measurement of subjective. So this is quite small and this is big. So you say more on the lateral side. Same goes for joint effusion. So you're seeing bulging of the anterior capsule and bulging of the posterior capsule. So there's a large joint effusion. And then when you're looking at that, you're thinking of any intra-articular processes going on. It's trauma, so I won't be thinking of JIA. But if you look again closely, you're drawing contours. If you come down metaphyses and suddenly you've got a little step here, okay? And then you wonder, yes, I know physis can be irregular in the distal tibia, but I just wonder if there was just a little bit odd in the front bit here. And then if I take a look again, thinking, okay, is this a fracture? There is a lucency that's just behind this at the tibia of epiphysis. And if I give an additional history that the child is probably 14 or 15, a boy, or 12 to 13 when you go, and that's when your epiphysis starts to close, then you're thinking of ankle fractures that's specific to the closing epiphysis, okay? And you can see here it's a little bit wider on the lateral side and a bit more fused on the medial side. So this is a kilo fracture. So this is very similar to what the triplane fracture, but these are ones that only occurs in the closing physis. So it's an intra-articular fracture through the epiphysis and then along the physis. Okay, they can be hard to spot and easy to miss. So if something doesn't add up, you go back to the clinicians and say low yield for MRI, like you rightly mentioned. But of course, if you can see it on the X-ray and they just want to know how to manage it surgically, then sometimes they ask for CT for better characterization. So ankle abduction, external rotation, that's a mechanism that's quite similar for a lot of the other ankle injuries that you get in adults. It's often that. And then depending on whether it's internal external rotation, you get the medial bands of ligaments or lateral band of ligament injuries to that. So as I mentioned earlier, there's a fracture pattern. It's vertical fracture through the distal epiphysis and then through the lateral physis, a horizontal component, and this off the ankle. So tilo fractures of the ankle. So metaphyses, so knowing how the metaphyses closes is important. So it is why a lot of it goes through the fracture line goes through the open physis, so laterally, because it starts centrally, then it goes medially, the closure, and then finally the lateral physis closure, hence accounting for the pattern of injury. So I'm not going to let you go through this case because I think I've already mentioned it earlier. So this is the other slightly more extreme version where you've got that nice line through, and then through the opening of the lateral unfused physis, you can say, central is definitely closed, medial may be closing because there's a bit of lucencies here and a bit more continuity here, and this opened, and then when you see on a slightly rotated view, you can see the fracture going up here. Okay, so this is a triplane fracture. And I said earlier, so CT helps with your characterization for surgical planning. Okay, we're going to a different type of lesions now. We're at the end, nearing the end. So candidate 4, do you want to have a guess what these are? So baby, it's an infant, less than 1 year old.
Of the foot of the knee joint, showing a large soft tissue mass lesion on the dorsal aspect of the dorsal aspect of the distal femur. The adjacent bone appears normal. It's quite far away from the bone. So this is a soft tissue mass for which an ultrasound is performed. The ultrasound is showing that it's heterogeneous, predominantly a hyperechoic area with increased vascularity. If it was compressible during the ultrasound, then this could be a hemangioma.
Okay. Same diagnosis, different case. And then after you kind of go through this, you tell me what you think. So what your conclusion is.
Okay, so this is a T2 weighted MRI coronal of the brain. The brain and CSF spaces are normal. There is a T2 hyperintense area in the left parotid, which is showing on ultrasound. It is well encapsulated and showing vascularity. Okay, there is an internal septa, so this could be a liposarcoma.
Okay, so I said this is the same diagnosis. So you've gone from possible hemangioma to liposarcoma. What do you think it is? So same diagnosis, just different cases. Going with liposarcoma, or are you going with hemangioma?
I think hemangioma.
Yeah. Okay, so these are hemangiomas. So often they present, you can have congenital forms which present at birth, or you can have those that present a bit later in life. So this is purely soft tissue, like what candidate 4 mentioned, no bony involvement. And on ultrasound, it can be quite a heterogeneous lesion, quite well circumscribed, because hemangiomas are vascular tumors. Okay. They can be compressible, so sometimes they're not so compressible. The more compressible one tends to be vascular malformations, like veno-lymphatic malformations, where they've got more cystic spaces. And the key thing is that with hemangiomas, they're often very richly vascular. They can happen in the limbs, they can also happen in faces. I think you mentioned this might be parotid. Good thought. The only thing here is that because I haven't given, I think this is a fairly well-centered coronal view. If it was parotid, you should be able to see the other parotid on the other side. I'm not sure you can see it here. But this is just an example to show craniofacial hemangioma. Okay, so again, very heterogeneous, but fairly well circumscribed lesion with quite a lot of vascularity. It can happen anywhere. And they can, so in the infantile ones, they can they develop quite quickly in the first 6 months, but they can also involute. There are different subtypes, like partially involuting, completely involuting. We're not going into that here because I think that's really more subspecialist diagnosis there. But I just keep it simple. So if it's a very vascular lesion, and if you've got this overlying skin changes, great. You can, and then history is important. Okay, so when did it start and how is it developing? So an ultrasound is one of your key things. You do an ultrasound first for any lumps or bumps in the kid. Hypervascular, rapidly enlarging or decreasing depending on when you image it, with a large number of vessels, and you get arterial flow in them. So if you are saying, how do I differentiate from the arterial flow from hemangioma versus arteriovenous malformation? So if you think of AVMs, they are like, so one of the bosses used to tell me, AVMs are like the ones that you do, your renal fistulas. If there's a thrill, you would think that clinically, you think more of an AVM than a hemangioma. Okay, because if not, there'll be the shunting, and you see these large veins surrounding it as well. So ultrasound can help, but sometimes it can still be difficult to differentiate. Okay, so you always, or at least for us, because we are not a surgical center for them, we refer it on. Okay, next one.
This is a frontal and lateral radiograph of the femur, showing a hyperdense area in the dorsal aspect of the proximal femoral shaft. Okay, on ultrasound, this is heterogeneous with central hyperechogenicity within. This would be a calcified lesion, like soft tissue neoplasm. There's no involvement of the underlying bone.
Okay, so I'll give you more history. So there is a bit of like, okay, and not much of soft tissue changes, but a mom says when the patient gets, when it's particularly active, you look a bit closer, you wonder if there's some calcification within the soft tissues here. And then perhaps this could relate to this.
If it's reducible, then it could be a.
It is compressible as well. It's compressible on ultrasound.
So this could be hemangioma again with the phlebolith.
Yeah. Yeah. So hemangioma, as I said, is a vascular tumor. Okay. So I think if you wanted to say, so yes, so this is not a hemangioma, but this is the other side. They are called vascular malformations. And I'll explain the difference in a bit. So you're right, these are phleboliths, and the reason why I gave the history, so they are usually they are just dysplastic vessels, okay? It can be lymphatic vessels, it can be venous vessels, normally, or mixture of venolymphatics. Unlike hemangiomas, which are tumors, these are more ill-defined, and they also demonstrate very low flow. You can sometimes get some papers say you can get a bit of arterial flow, but generally they are really slow flow. So you've got to turn your Doppler settings down or use power Doppler to even pick up a little bit of flow. And we've got, and the giveaway sign is the phlebolyths within it to suggest that it's very low flow. The reason why I mentioned the history is because if it's a venous one, often you get intermittent swelling when you use the limb just because of the diversion of blood flow through these spaces. And if it's a more lymphatic one, then these would often swell when a person's unwell or the patient's unwell. Okay, so the venous one a bit more dependent on activity, but the lymphatic ones often when there's a change in your lymphatic system, so like when you're unwell, a general rule. Then going on to MR. So when you see that, some people, or rather some clinicians, if they wanted to operate on it because it's very extensive, they'll ask you to do an MR. And MR just shows you, so these are the post-contrast pictures and the post-contrast and pre-contrast ones showing just cystic spaces or cystic signal ill-defined lesions, but they just look like quite bubbly. And in post-contrast, you can have a bit of even if just depending on how delayed you acquire these images, you can get enhancement within them. Okay, this is more on a difficult spectrum, but it's just to complete. If we're talking about hemangiomas, then we need to talk about the vascular malformations as well, but it's unlikely to come out with exams. So I think, as I said earlier, the vascular malformation is more of a vascular dysplasia, so it's a dysplastic channels, or hemangioma. I think we hadn't gone to that slide, sorry. Oh yeah, so we did to do this, sorry. Or hemangioma is more of a vascular tumor. So vascular malformations can present at birth and it grows with the child. Okay, sometimes it can involute, sometimes it doesn't have to. And it's one of the most common in the venous ones. The venous forms are the most common vascular malformation. And we said earlier, so soft tissue mass phlebolyths. You can sometimes, because of the change in blood flow in that region, you can have periosteal bone formation. I really haven't seen that. Vascular channels, large cystic spaces. You can have these like fatty type connective tissues intervening or cystic spaces. And you can, often it's more low flow than high flow, and Dopplers want to help you to identify the flow or in waveforms. And MRI if surgical intervention is considered. So this is one of the this is the way I think about it. I think there's an ISSVA classification from 2014, but vascular anomalies, if you're not sure what it is, that's the umbrella term. And then if you go into, you can then subdivide it into hemangioma or vascular malformation. And then hemangioma, again, more tumor-like, vascular malformation, more ill-defined area of dysplastic vessels. And you can then further subdivide it into, so clinical assessment is important, okay, because history helps you to go down one or the other path, and then following that you can then split into either AVM, so often use the thrill, or you can see the very large veins because the AVM, venous malformations, I said, lymphatic or combination of both. Capillary malformation we don't often ultrasound because they are clinically diagnosed as with the skin changes. Okay, so if you have, the only thing is if you have capillary malformation, often what you do is you do brain imaging because you want to exclude a Sturge-Weber syndrome because it's higher risk. Okay, so last few slides now. Candidate 4, last slide.
Okay, this is surgical ultrasound image of the left leg in the plantar aspect. There is a heterogeneous area in the plantar aspect of this image. I'm provided also with MRI. MRI is showing T1, which is hyperintense. On T1 fat saturation, this is partially suppressing, and on T1 post contrast, there are some internal enhancing septic. So this could represent due to incomplete suppression and some enhancement. I'm thinking of a liposarcoma.
Okay, so this is a lipoma. Before we go there, can you tell me why you think it's a liposarcoma?
Because it was not completely suppressing on the suppressed image. Also, there was some internal enhancing septic on the post-contrast.
Okay, so in lipomas, you can sometimes get a little bit of internal enhancement. So on ultrasound, you can have a little bit of internal vascularities, and you can also sometimes get a bit of septations. I think what's more, if it was a liposarcoma, then things that you're looking for is nodularity, of course, enhancements of that nodularity. But just also remember, this is in a child versus an adult. A lot of those criteria, although it can also be applied to a child, but often are applied in the adult population. In a recent talk that I went to, the most common type of liposarcomas in kids are myxoid liposarcomas. And because its myxoid component often looks very cystic. When we go back to this ultrasound, it actually looks quite solid rather than cystic. So making a myxoid component within the lipoma or liposarcoma less likely. Okay, it's not saying never is never, but this is more in keeping with a lipoma than a liposarcoma. But like you say, I see where you're coming from. So of course, in doubt, you refer it to the surgeons to get them to take it out, or you keep an eye on it or monitor it. But I think malignant change of lipomas in the liposarcomas in children is not common. Okay, it's uncommon. So most frequently subcutaneous, but I think we got this. There's ones that not subcutaneous. Ultrasound is very variable. It can be hyperechoic, isoechoic, hypoechoic mix, depending on the type of fat in it. And on MR, you have complete fat suppression, but you can have some septations, and you can have a little bit of a contrast enhancement as well. Okay, again, I don't think this is a topic that would be given to you in exams, because it's really more of a specialist type. Okay, yeah, I think that's the end. Yeah, so a summary of what we've covered today in the second section. I think we've covered DDH, some vascular anomalies. Just remember, it's just the age. So kids, so of course in toddlers, we didn't cover transient synovitis, but essentially it just looks like a joint effusion, often diagnosed on ultrasound. But ultrasound cannot tell you whether it's infective or reactive synovitis. So often you need clinical features to support it, whether it's transient synovitis or septic arthritis. Because of the child, okay, the transphyseal vessels. Birthdays, you get it in the 4 to 8 or 3 to 10. Of course, JIA happens anywhere under 16. Trauma, you think of the avulsion fractures, you think of the tilo fractures, the triplane fractures, your osteochondrosis or your osteonecrosis, Perthes, Penners, Freibergs and whatnot, CNO, CRMO. Lipomas can happen really in any age. And of course, all the other ages, you think of septic arthritis, pyomyositis, osteomyelitis, and what we didn't really cover today is metabolic diseases, but at least we went through some stress fractures and some insufficiency fractures. Okay, so that's the end of session 2. Sorry, this was really a whistle-stop talk of some of the pediatric MSK stuff. Feedback forms. I don't know if you've got any questions. I'm going to invite, if Geeta's still around, to join me in the Q&A.
Sure. Okay.
Geet, do you want to add anything on the lipomas, of the pediatric lipomas?
No, nothing. I think you covered everything really nicely.
Okay. I think we've dropped quite a few people. If you've got no other questions, we're just going to leave we'll just wait for a few more seconds. If you've got any questions, type it out in the chat and we'll try to answer it. If not, then thank you for joining us today, and we'll see you next week on tumors, abdominal tumors, urology pathologies, and CNS tumors. We couldn't cover it today because there's just too much MSK to cover. So apologies for that. Okay, so thank you all. I don't think there are any questions. So I'm going to leave this slide here for the next 5 minutes, and I will